All right, we're just waiting for everyone to join into our call today. We still have some folks in the waiting room, so just please give us a moment as we get everyone seated in this virtual Zoom space. We're delighted to have you here with us this afternoon at this COVID-19 Roundtable, a Provider Summit. So please just bear with us as we admit everyone from the waiting room, and we will be starting shortly. Great, it looks like everyone has been seated in this virtual space. And again, I am Dr. Delara Uscoop, one of the co-PIs of this project. We are so excited for you to join us this afternoon for this COVID-19 Roundtable, a Provider Summit. Dami, if we can get the slide deck going, please. And again, we're here to share updates, best practices, and strategies for increasing vaccine uptake here in Los Angeles. I am part of the UCLA Center for Behavioral and Addiction Medicine and the co-PI of this project. I am joined by the other co-PI of this project, Dr. Stephen Shoptaw, who is our fearless leader here at CBAM. And here we have the rest of our research team who has been doing all of this work around COVID-19 vaccination uptake. So we thank you to Dr. Harawa, Wen, to Dami, to Dr. Shover, Dr. Mays, and Enrique, the entire team here at CBAM. Next slide, please. CBAM is a multidisciplinary center that seeks to advance the prevention and treatment of chronic illnesses. They also conduct clinical trials and behavioral studies. And the focus here at CBAM is on communities with health disparities. CBAM led the COVID-19 Moderna vaccine clinical trials at the Vine Street Clinic, and I am so delighted that the two moderators of our discussion this afternoon are going to be two doctors who were right there, boots on the ground, in that COVID-19 Moderna vaccine clinical trial. So I do hope that as this conversation moves forward, that they will be able to share some of those insights from that clinical trial setting. Next slide, please. This is our project on COVID-19 vaccine uptake, and our project is funded by the California Community Foundation. The aims of our project are threefold. The first aim is to facilitate community, public, private, and governmental partnerships to reduce COVID-19 vaccine inequity. That's why we are all here. We want to reduce vaccine inequity and increase uptake. We also want to educate communities in South LA about the COVID-19 vaccines through virtual town halls. So we had virtual town halls spanning across the spring and summer with community leaders, as well as the broader community, both in English and in Spanish. And we hosted a series of focus groups with these groups, and we had a provider focus group last week. Finally, our goal is to navigate communities of color in South Los Angeles on how to access COVID-19 vaccines. So we want to, do things academically, have the research, but we also want to help communities of color actually get to the vaccine. Next slide. If you have any questions, if you want to partner, if you want to collaborate, if you want to learn more about the work that we're doing with CCF or the other work at CBAM, please don't be afraid to reach out to either me or Dr. Shoptaw or Dami, and you have our email addresses attached. And for anyone who's joining, we want to thank you for attending this provider summit. So now that we've gone over the goals of the summit today, I want to introduce a PSA. And again, our goals today are to share updates around COVID-19, best practices and strategies for increasing access and uptake, and approaches for community engagement and lessons learned for the future. And we have an all-star, as I said, all-star duo of moderators and our list of speakers, with which our moderators will introduce a little later. Before we get to our discussion with Drs. Adiga and Dr. Clark, we're going to play a PSA that we put together in collaboration with Kedron and CCF. So if we can get that PSA up.
I got vaccinated for my family.
For youth sports.
To go back to school.
Let's get the whole country vaccinated. Let's end this global pandemic now.
This is based on math and science. This is a great way to prevent people from dying.
Los Angeles, get vaccinated.
This is indeed our shot. And I know there may have been some audio issues, but we will be sending out that link to that PSA. Without further ado, I would like to bring to the stage Drs. Clark and Adeyega to lead us into this discussion section of our presentation today.
Thank you, Dr. Yuskop. My name is Jesse Clark. I'm an infectious disease physician at UCLA and medical director of the UCLA Vine Street Clinic. Dr. Adeyega.
Hi, thank you, Dr. Clark and Dr. Yuskop. Really delight and honor to be here. I work as an infectious diseases doctor at UCLA and really been assisting with the Moderna trial as just working on that, as Dr. Yuskop said, but delighted to be here and participate in the discussion.
So joining us, we have some wonderful speakers today. Do you all, we'll just give people a chance to introduce themselves individually, starting with Dr. Abraham.
Yeah, great. Thank you so much for having me. Dr. Jerry Abraham. I'm the director of Kedron Vaccines here in South Los Angeles. We have vaccinated over 300,000 people in our community. We have tested hundreds of thousands more. We have now taken the vaccines to where people live, work, worship, play, where they go to school, reaching the homebound. And it's a lot of work with very few hands. So we are very busy, but we're excited to be here to share our lessons learned and definitely to continue to advocate for so much more that needs to happen to make sure our communities are safe and protected. Thank you.
Thank you, Dr. Abraham. Dr. Guerrero, would you introduce yourself, please?
Yes. Hi, everybody. Thank you for inviting me today. I am a general pediatrician, and where I do my clinical work is at the Venice Family Clinic. And yeah, I have to say that I'm thankful that I actually don't have to do a lot of, sort of like counseling and encouragement to get our eligible kids, depending on their age and their parents. And, I think we're just going to keep kind of doing that. And I know that our clinic as a whole, I think, has taken some outreach teams into the schools. Like we are surrounded by, I think, at least 3 schools. And so we've had teams set up, a station, and they're offering parents or anybody else who's eligible after school. So I'm glad to see that outreach is going on.
Great, thank you. And Dr. Biel, would you like to introduce yourself?
Sure, I'm Dr. Tracy Biel, and I'm with the Department of Public Health. I work with a lot of the folks on the phone, making sure we have COVID vaccine equity in terms of resources and the vaccine pop-ups, clinics, and anything else in between to just make sure we are addressing the needs for the communities of color and vulnerable populations. Thank you.
Great, thank you. Dr. Wallace, do you want to introduce yourself?
Sure. Hello, everyone. Thank you for the invitation. Stefan Wallace, Director of External Relations for the HIV Vaccine Trials Network and the COVID-19 Prevention Network, federally funded by NIAID to coordinate all of the COVID-19 vaccine trials under Operation Warp Speed. So I work in the Operations Center where I lead external relations as well as communications. Happy to be here. Thank you.
All right, thank you. And finally, Dr. Young.
Hi, everyone. Thank you so much for having me. Hello to everyone that I've see on this call that I've worked with in the past. My name is Sheila Young. I am an assistant professor in the College of Medicine at Charles R. Drew University of Medicine and Science. And I've been involved in community outreach on the ground with community members in South Los Angeles, testing and vaccination.
Great, thank you. And for all of our speakers, as we get going, I would like, well, if you have questions for any of our speakers as we get going, I'd like to remind you all that you can post comments or questions in the chat or send anonymous questions using the link also provided in the chat. Also, there's going to be a raffle at the end of the session for those who've registered. A number will be selected that will correspond to a last name and initial of your first name. Only those who've registered and are present for the drawing will be eligible to win. Once the name is called, the individual should respond if the chat is present. And then do we have a brief poll for people to take? Yes, so please take the poll, which should have appeared on your screen.
Can I just jump in and say, if you're not seeing the poll, on the bottom of your screen, there is a line of options and you will see the option poll. If you click on poll, that should provide you with a poll. So it should pop up on your screen. If you're using a cell phone, you might need to click more and you will see where it says poll, because I do see that we only have 4 people that have participated. So it should be at the bottom of your screen or you click more on your cell phone. Someone told me that it had closed already, so I guess that was really fast. If you don't mind clicking it and taking the poll. Thank you. All right. Thank you.
Is that everybody for the poll? Okay. Dami, can we go on?
Please.
Okay. So to start off the discussion, we just want to talk about, ask our experts, what's the current state of COVID-19 in LA County? What's the epidemiology? What's the situation with mask mandates, vaccination policies? And what's the impact of the Delta virus on all of this? Basically, what's your take on the overview of where we are with COVID right now? Dr. Abraham, do you want to start?
Sure, I'll take a stab at it from more of our community-based testing and vaccine program. Where we're at right now, schools have reopened. There's increased demand for testing all around. Delta variant is spreading. There are still those holding out to get their first and second doses, although we're seeing more employers, more educational institutions requiring vaccines for enrollment or to remain employed or to come into the workplace. And I think we're going to continue to see that accelerated. In the last several weeks, we've seen exciting things like Pfizer achieving full FDA approval. And that also, we believe, has contributed to an uptick in people getting vaccinated and more vaccine confidence. But we also need to prioritize those that are needing third doses because they never achieved the immunity or the protection that they needed from the first 2 doses prioritizing our cancer patients, those on chemo, those on steroids and others. They need that third shot now. We are continuing to ramp up our capacity for everyone to get a booster 6 to 8 months after their second dose. And we can start doing that as early as September 20th is what we're currently understanding. We're watching to see if Pfizer, Moderna, Johnson & Johnson continue to develop or roll out newer or next generation vaccines. That's something to watch. We're watching how the 5 to 11-year-olds are doing in clinical trials for Pfizer and Moderna and anticipate a elementary age vaccine available come, October or November. That will also be a game changer for so much of the population that's left out of being protected and vaccinated. But of course, we need to continue all of our layers of protection, including mask wearing, appropriately socially distancing, good hand hygiene, in addition to everyone eligible needing to get their vaccine. So that's kind of perspective from our end. The work is exhausting. It's 7 days a week. It's going to where people live, work, worship, play, to churches, factories, schools, to reaching out to the homebound. And the results are very low numbers compared to the 3,000 to 5,000 that we were used to or accustomed to during the height, when we had many more volunteers, many more hands on deck. And so this is that last mile. This is that health equity mile I always talk about. It requires more resources. It requires more of an investment, but that's the only way that we're going to achieve this last mile and get to our destination where our communities have 70 to 85% protection. And that's the herd immunity, the community immunity that we need to achieve. And we're just not going to be willing to leave people behind and continue to leave people hardly reached. So thank you for everybody that's definitely doing their part. And that's just kind of from our perspective on the ground. Thank you.
Thank you, Dr. Abraham. And Dr. Biel, can you take us through the county health department perspective?
Sure. Although LA County as a whole is doing relatively well with vaccinations, we have 74% of the population vaccinated. And in the senior community, it's like 90% are vaccinated. The challenge we have is in the Black and Brown communities, primarily the Black community, where we have almost half of Blacks vaccinated. In some communities, it's a lot less than that, versus where we see white and even Native Americans are vaccinated at 70%. So Latinx community is about 60%. So there's a 10-point spread. The problem in terms of what that means, what that translates to, is that we have more Blacks in the hospital, more Blacks that have cases, more Blacks in the ICU. We also have the higher death rate right now. And we also have some challenges with the age groups. The youngest population that's eligible, ages 12 to 15, only about 60% are vaccinated, and they're back in schools. A lot of schools are open, so that's a challenge. They also are in a lot of multi-generational households in a lot of our Black and Brown communities. So the spread that we're seeing is more family than work site, even though we do have work site cases. And also the 16 to 17-year-olds and the 18 to 29, the younger folks have the lower vaccine rates even in the Black and Brown community. So the push is to really try to up the awareness of what that means and how the Delta variant, we used to have maybe 2 cases for every one. We're having 5 to 9 cases per spread. So the spread is really pretty rapid, and it's pretty broad-based, meaning all these pockets of unvaccinated, we do see that's where our major outbreaks are, the top 3 areas. Okay, thank you.
Thank you. That's horrible information, but good to have. Dr. Guerrero, we've been talking a little bit about the situation with children. Can you tell us your perspective on what's going on with the pediatric population, both in terms of who's getting infected and then who's potentially getting vaccinated? Dr. Guerrero? We may have lost Dr. Guerrero. Okay, so Dr. Wallace, if we could talk about the vaccine response. So people are talking about the Delta variant.
I'm so sorry. I was just like struggling trying to figure out how to turn things back on, but happy to try to answer your question in terms of like, what am I seeing in pediatrics? And so a little bit of background, I'm on the, what we call like the west side of Los Angeles, but it's a federally qualified health center. So it's a largely Latino immigrant, sort of population. And what I am seeing, I think really echoes what I think Dr. Tracy Biel was bringing up, that it's oftentimes the younger ones, like the sort of the toddlers, preschoolers that are frequently coming in for testing, not so much the, elementary, high school kids. And like I said earlier, I have been fortunate that I work in a community where I don't think that there's certainly not a lot of hesitation. And many of the kids actually, as I'm seeing them come back for physicals, have already had it placed. So it's a really, I think and I think it's responding to all the efforts, right? I know that as all of you have shared, you're doing some aspect of outreach and engagement. And it's really, at least from my perspective, nice to see, a lot of our younger kids or teens and older teens having their vaccination in place. So far, that's what I'm seeing. It's usually those that are like in a younger toddlers, or, like those that might be in an early education center, and largely because, they're the most vulnerable in terms of not being able to be vaccinated, and they're following protocols, right, to get tested before they go back to school, should they have any symptoms. So that's a little more of the flavor that I'm seeing. And I can tell you also, I'll add on, my husband's a high school teacher at El Sereno. And he sort of shared with me, that it actually hasn't been as difficult, I think, as he had imagined. And one of the things that I was thinking about as a pediatrician was the degree of phone calls or requests for visits. If many of my kids are in the Los Angeles Unified School District. So my thought was that we would get inundated with calls, because they're not surveillance, they're screening, right? I mean, they're giving a test to these kids like every week, and all the teachers. And so I thought to myself, oh gosh, there's going to be many, like positives, and they're probably going to be asked to, for letters to go back. And I also had brought up the issue to my husband. So if someone tests positive, but they complete, their isolation, technically we're not supposed to be testing them again after 90 days. So how is the school going to manage, that piece? And I think that he shared with me that there probably isn't a whole lot going on to respond to that next step. I think schools have been really focusing on just getting that testing done, right, every week. And like I said, so I was expecting something different shortly after the 2-week mark. And many of our Unified School District kids, I think, started, I want to say like closer to 3 weeks ago. And that it's been kind of quiet on that end. So I think I'm very, very happily surprised that it's not a different sort of picture.
Excellent. Dr. Young, given your work with testing and vaccine outreach to local communities, do you want to build on what Dr. Guerrero was just saying, what the situation with testing and vaccination in local communities is from your perspective?
Yeah, sure. So one of the things that I'm going to say outright is that with looking at essentially the Black community being less than 50% vaccinated, I think it's important to reanalyze our strategy and look at other options or additional options in our approaches. So I think that those who have made up their mind have made up their mind. And so we've got to shift. That's, I think, the most important thing that I wanted to bring to the discussion today. What can we do as providers, as community leaders, to find a different strategy? I've got a couple of ideas that I can present later, but we're definitely seeing a lot more people being tested, and that's also because it's being required. So I think that we've got to look at that whole situation. What is working and what is not working. If folks are being required to be vaccinated to go back to work, I think that we need to be real and understand that people are going to present false information. We already know that that's been happening. And so we've also, we just have to understand how humans behave, what they're going to do, understand that people are not going to mask properly. And we really have to get in front of this virus.
Great, thank you. And then back to Dr. Wallace again. Since given your role in the vaccine research, can you give us an overview of where we're going in terms of vaccine with boosters, tailoring to the Delta variant, that sort of thing?
Thank you for that. Where we're going is where we are now. The data is pointing to the fact that we are considering boosters at this point, not only for people who are immunocompromised, but for everyone. I think it's really important to your point that, and to Dr. Young's point as well, that we think about as researchers, as healthcare professionals, how do we message these concepts? How do we message these topics to our communities? This is a really important point, particularly when I think about the messaging that's out there now, that we are in a pandemic of the unvaccinated. And I think about how disparaging that comes off to many people. And what do we need to do to bring people back into the fold and to move people along this continuum? I think about the stages of change model, and certainly disparaging and shaming people into behavior change is not sustainable, nor does it work. So how do we restructure our approaches and our messaging? And again, to your question, we're at boosters. That's the conversation we're at now. We're looking forward to seeing Moderna receive potentially full FDA approval soon, and then shortly after that will be Janssen's turn to sort of move forward. And we're also looking at another vaccine, Novovax, that showed efficacy in interim analysis and as well as the primary results. So that one will be likely moving forward as well. So we'll have lots of options. The other thing that I will remark on, since you asked about variants, is that this is not a pandemic isolated to any one particular region in this country or to this nation, and that this is a global pandemic. And it is critically important that we also message correctly how we need to approach this, the factors that are causing and really undermining the way that vaccine access and distribution can happen globally, and that we work effectively to address that as well. Thanks.
And Dr. Wallace, could you also speak about the question, which has been alluded to already, about the vaccines for under 12, where we are and where we're going with that?
We're still waiting for results from those trials. I know that Pfizer and Moderna both did studies in that regard. And so looking for the data from that to move forward. And hopefully we'll see that happen really quickly, and the ACIP can respond and react quickly as well after FDA review, so we can get this out. I know there are many people who are thinking about this and who are talking about this. And this is another area that I think is also really important consideration when we talk about messaging and community information. So,
great, thank you. And so, why don't we pivot now and talk a little bit about how do we encourage vaccination at this point? Like Dr. Wallace has just said, we're sort of at this bizarre situation now where we've got people who are going to be banging down the doors to get their boosters, while we're still trying to get people to come in and get their first shot. And plus, worldwide, there's plenty of people who would be busting down the doors to get their first shot if they could. Dr. Young, you said you had some ideas for how we could promote vaccination better in the future. Do you want to talk about those?
Sure. I think that the thing that I've been pushing for the last several months is that we release Novovax. It's available. They've got the doses ready. It's not Novovax themselves that are holding off on pursuing the EUA, but it's the Department of Defense. And so we have something in our tool belt and we're not using it. I think that we would be able to get at least another 15 or 20% people vaccinated, especially in the Black community, if we were to release this vaccine immediately. They are looking at using Novavax in other countries. They were looking at releasing Novavax in the Philippines. in September. But again, the company is ready to release. So why have we not released it? The other thing that I think is important, understanding and knowing that individuals in Black and Brown communities have higher rates of comorbidities. South LA, we have the highest rates of diabetes, high blood pressure, complications of diabetes, including and high blood pressure, including end-stage renal disease, amputations, blindness. We have to understand that even folks who were vaccinated are still at risk. And so I do believe that another thing that we have in our pocket is, treating people once they were identified as positive and not necessarily sending them home. Why can't we provide folks with monoclonal antibodies when they test positive? We have things in our tool belt. We know azithromycin doesn't necessarily work, so why are we still prescribing it? So there are things that we have in our tool belt. I think that it's important, again, that we have these forums where we can come together, and then we all really have to be on the same page, because the thing that is hurting us in this pandemic is that folks feel frustrated because they're getting a lot of different information and they don't know who to trust. And so when you have information coming from, the upper echelons of government, and the media promoting certain things, and then you've got us on the ground saying, hey, wait a minute, that doesn't apply to this community. It's fine if you don't wear your mask, if you're walking outside, walking your dog around your neighborhood. But it's different if you're working outside in a swap meet or working outside in a factory where you're close to people. So we really have to, get our messaging. It has to be clear. We as a physician scientist community, we've got to get on the same page. And I think if we're able to do that, we could really move forward. But we have a tendency in medicine and science to, sort of always question each other, or sometimes we put each other down. And so this is not the time for that. We've really got to come together. If masks are what we have to do, let's just keep masks until we're through the pandemic. So those are strategies. We've got to treat people early. We've got to get people oxygen. There is a company called Inogen that's able to use or produce compressed oxygen. All we need is the tubing. It is expensive, but we can provide things to folks so that if they are sent home, if they're not admitted, at least they have something to support them. So we know how to keep people alive with COVID. We've just got to do it.
Great points. Can we talk a little bit more about the Novovax vaccine as well? How is it different from the Pfizer or the Moderna vaccines? This is for anybody, any of our panelists.
I can go about it. So the Novovax vaccine is a protein-based vaccine. It is just the spike protein. So when I've been a part of community forums, Dr. Biel and I have been in many together, some folks just don't want anything that enters their cells, or something that's called mRNA or DNA. And with all the misinformation that was put out in the beginning, folks are scared. And, we have to acknowledge that, find a different strategy, and move on. And so, again, I think that knowing that this will not enter their cells, knowing that it is similar to a flu shot, the inactivated or dead, or the portion of the flu shots like that we have available now, letting them understand that, and then really being transparent about the fact that getting a fever is not a side effect. It's demonstrating that your body is actually mounting the immune response that it's supposed to. So again, clearing up that messaging and really saying things in a way that folks can understand is key. So if they know that nothing's going to enter their cells, I think that more folks would be willing to get the Novavax.
Great, thank you. And this is going to go to Dr. Biel, but anybody else also feel free to chime in. Talking about these issues of mistrust and misinformation that are out there, how do we combat these? And especially, I think a big question now is how do we combat misinformation, mistrust among medical providers? Because we've seen even now physicians and healthcare professionals spreading, false truths about, or spreading myths about the vaccines. So how do we combat these as a community?
I think the medical providers actually need to address it within their own forums. There's a lot of medical associations. I think they really need to come front and center and be assertive about it and call each other to task. That's what I think should happen. But the other thing I will tell you, as far as misinformation, and I was dealing with New Orleans, which, as you guys know, is underwater right now. But a few days before that, they called me in desperation. And one of the ways they were able to get people to get vaccinated after we talked about it, they said they had a lot of people outside of those hospitals standing for the family members that were inside. And I said, why don't you guys put up some vaccine sites and some education, have people out there. And they said, that was really eye-opening because people were willing to talk because there was a person in the family in the hospital. So my thought is you need to go and meet people where they are in what I call a teachable moment. And I even talked to people in Atlanta where my family is, and there are so many funerals, right? So I talked to one of the big undertakers that said, we hadn't thought about this, but they put educators and vaccinators right outside of their facility, which sounds odd, right? But so many people are coming to see viewings and wakes and things that sounds odd, but I think you have to meet people in the moment. And that seems to be when they're more willing to take some of that misinformation and put it aside because something traumatic has happened in the family. And I know that sounds like an opportunistic approach, but in my world, I'm thinking the movable middle, those people who are kind of on the fence, those moments are when we can galvanize them to move forward. So I just think we need to be more creative, and even the resource approach as opposed to one standalone event. I know Dr. Nana, Dr. Abraham, and Young have been at these big, events or small events, but the largest event I've had was like 4,000 people showed up because it was all the school supplies and everything in between, from mental health support to everything you can, resources for electricity that had been turned off, rent resources. We had people lined up and we had people talking to them while they were in line. They weren't necessarily there for the vaccine. We happen to have a vaccine there. So I think we need to repurpose how we look at engaging people in a place where they would be acceptable to getting the misinformation discussed in a better way because they have other needs other than the vaccine. So that's just what I've seen be more successful.
I would actually like to chime in there also and add to what Dr. Biel was saying. Something that I've also seen and have heard quite a bit come up is healthcare professionals and other persons who are describing this sort of this pushback that they're often getting from communities, particularly from our communities, because they're seen as the mouthpiece or the voice of pharma, right? And I think that this is something that I think also deserves a conversation in the forms that you were describing, Dr. Biel, because I would imagine that the nuanced ways in which I've heard it are not the only ways that people are experiencing this. And so that's the first point. The second point is I think it's also really, really important that we continue to rely on community leaders and building scientific and really health capacity, health literacy within communities in order to respond to misinformation and to dead it as soon as they hear it. Like, what does it mean for a community to be empowered and to have information so that as misinformation starts to flow through, they can completely kill it. And so any strategies that are working in that regard, I think are really important as well. We're seeing that in spaces that we operate. So just wanted to put that into the room.
I just want to jump off of that as far as the messaging. It also takes funding. So, we can advertise on KJLH or 92.1 Beat or, a lot of the other La Raza. We can advertise on these stations, but they don't do it for free, even though it is for public health, unless Dr. Biel, you make them. But there, we have to understand, and I just want to know if we could just have an honest conversation. I mean, what can we do about the misinformation coming from the media as a medical community? I know that, sometimes I've been on and I've said one thing, and then, part of what I've said has been cut off, not all the time, but, we really have to, work with the leaders in our country. The information has to be vetted. We've got to, again, get on the same page and put out the proper messaging. When you're saying the pushback, especially among the Black community, it's because they feel that they've been targeted. It's also because they've been blamed and shamed. And again, that's not going to work. What works is meeting, again, like Dr. Biel said, people where they are, but then also spending time to answer folks' questions and their concerns and being truthful about it. If we don't know something, we just say we don't know. And we have to be that way. We have to be transparent. And I found that when we operate in that manner, people are able to make their own decisions, and then they'll feel like they've made an informed decision. One of the other things we have to realize is that in South LA, for example, a lot of folks don't have a physician that they can just call up for a message. They don't. And then our FQHCs, are overwhelmed. The ones that we have here are overwhelmed. St. John's has been doing amazing work. Of course, Dr. Abraham has been doing amazing work. But again, like you said, everyone's stretched thin. I think we've all been, burnt out at some point during this pandemic, and have had to recoup. Some of us got COVID, but it's like, we really have to find a way, like you mentioned, Dr. Wallace, to cut off the misinformation immediately, even if it's coming from the media, even if it's coming from the upper echelons of government. And we've got to be okay saying, that actually, this doesn't work here, or this doesn't apply to this community, or you can't blame and shame them if they haven't had someone to speak with. There was an article by a New York Times staff writer, just saying it's the fault of the Black and Latino community that we have the Delta variant. Well, honestly, were they traveling? Were they ones, leaving and coming back? No, they weren't. And so you can't blame the oppressed. I'm sorry, I'm just going to say it that way. You can't blame the oppressed. They are not the cause. Folks were unvaccinated still, and we still got the Delta variant. So it's folks who are traveling. I had to go to the mall the other day, and I just couldn't believe it. I just felt like everyone's acting normal, but we're still in a pandemic, So we've got to really change our messaging. And then we also have to be honest about the economic factors that are at play here. People have made millions of dollars during this pandemic. Of course, a lot of people have lost out, but a lot of people haven't. And so we've got to understand, what is in the best interest of our patients? What is in the best interest of our community members? Is it in the best interest of kids who are unvaccinated, or kids who, go to school and may expose a family member? Are there other measures that can be taken in the home? So those are the other things that I'm talking about as well. What other ways do we need to approach families? Maybe it's more education about, having windows open, limiting who comes over, making sure that you wear a mask when folks are over, installing, a HEPA filter in their house, in the air intake, or getting an air purifier that has a HEPA filter. My son just went to college. I didn't want to really send him. He is in a dorm. I didn't want to do that. But he said, Mom, I'm going. And I said, let him go. But I got him an air purifier that has a UVC light in it. At least he's got that. He's wearing a KN95 mask everywhere he goes. And so, that's the other thing, we've got multiple ways. We've got to look at those ways as well. We've got to get more masks out. We use that, why are we still on cloth masks? We don't have forward.
Can I follow up a little bit on what Dr. Young is bringing up? I think it's fantastic sort of thinking, right? In terms of like being able to go to where people are either getting their source of information or where we might find a group, right? Where do folks tend to gather? And so one of the thoughts that I had also, especially about the media, is you're right. There's such a disservice to to families, really, in terms of what gets covered. And I can tell you also that in my circle, I'll say, and not just my patients, but some colleagues, I don't know how prevalent it is for folks to get their information from Facebook. But I can tell you that in the, I can't generalize, but at least within like subgroups of Latinos, it's like wildfire, the way people go back and forth about what they've heard. That's one thing. The other thing, and it is related to sort of Facebook media, is you'd be surprised. I remember I had a teen who was giving the parent like false information. They're like, yeah, see, if you put what did they say? If you put a spoon next to where you got the shot, it stays. So like that's proof, that they're putting some sort of like, I don't know, chip, whatever it is their theory is, right? But I think sometimes too, we have to probably also think about, can we sort of leverage or, create some of our kids to also be communicating this to their parents or to their grandparents or whomever else. But, I think it, there's all of that. And that's not the kind of, we're not even talking about the media that is, news with, the kind we're used to, but it's rampant out there. And so I don't know. I know that oftentimes, like in the world of health services research, we sometimes use that approach, right? If you think about the behavior change model, you have to start with knowledge, try to change those attitudes, right? So first thing is that knowledge, right? And how maybe, can we use our youth who are probably on media a bazillion times more than I think their parents or grandparents, and try to leverage that angle, because it's unfortunate. I've seen some of the back and forth, and it's really problematic.
Thanks so much to everybody for all of the wonderful wisdom that you've been sharing and the work you've been doing in this space. There's been a lot of discussion about the need for new strategies to engage the community in these sort of discussions. And I wondered, for anyone who has had this happen, have you had any success stories where you've been able to engage individuals or specific individuals or groups of individuals who initially they were hesitating, but then decided as a result of this discussion that you had with them or whatever intervention that was used, that they, you moved the needle, or there was a change in mind, or willing to consider a change?
This is Jerry Abraham here. I'll just add, I think it touches on a very important issue, that everyone is different. Everybody's motivated differently, and it creates a challenge. There's not going to be any one solution. Plenty of people rolled up their sleeves and took their shot back in December. Black and brown healthcare workers, Black and brown seniors came to Kedron in lines, and that shot alone motivated several individuals. And yet for others, they do need that extra nudge or that gift card, and yet someone else finds that offensive. And so we're dealing with all these very complicated nuances that work for some, doesn't work for others, but definitely doing our very best to meet people where they are. I think frequency is important too, being visible and present consistently over time. And that is a huge investment in resources, but finally that 12th or 15th conversation or interaction or touch point may be what it takes. And we've seen that with several individuals who said no, and then over time, it's because Dr. Abraham came and spoke at their Sunday morning service that they finally, even though we had seen them before, they brought their relatives, but they were not going to get it. And they're like, Doc, you finally got to me, you know, and it makes sense. So that's okay too. We're going to take time, let people take time, you know, give them the space. And that, unfortunately, this current world in this healthcare broken delivery system does not have the patience to understand this is what it takes. And so we still need to kind of convince that to our dark healthcare overlords that this is what it looks like. And instead they just say, you went out and did all that and vaccinated 20 people. Come on now. And it's like, well, that, have you ever thought maybe what it really takes to engage every individual and the time and to be present and to care? Do you know what that costs and looks like? And that doesn't seem to be getting very far. So we're going to have to keep building on it. Lastly, I'll just add the network that we're building, the branches in the ground, the roots are the branches in the trees and the roots in the ground. This network has to remain beyond the pandemic. It is the only way for us to continue and to live and thrive and survive. We need to use this model to increase all school-based, childhood vaccines. We need to use this for cancer screening, for prostate cancer screening in Black men, colon cancer screening in our entire community. All those things, these are missed opportunities. So if I only take my vaccines out, I do feel like this is all going to be a loss. But if I can find some way to make these mobile efforts more permanent, this democratization of healthcare that removes us outside of the four walls of the traditional clinic and a hospital and realizes that health is received in housing and at school and at work and everywhere where people spend all their time and energy and love, that's the space that we have to help and heal and take more than just tests and vaccines. But people do come around. You just got to take time.
And this is Tracy. For me, I think one of the most compelling situations was having a group of very young teenagers who had all these myths, some I had never heard of about vaccines and what's in them. And we went all the way back to the slave that brought the concept of vaccination to the United States and to present day. And they didn't even realize that, historically Black colleges, churches had, and all kinds of folks had been involved in the clinical trials, but it took a lot of the Black specific engagement in the vaccine concepts to get this group of, they were almost militant with me. At one point I thought they were going to throw something at me, but it was funny that we did all of this leading up to a vaccine clinic. It took us about 2 weeks to do all of these subgroups with the different youth groups. And I was fascinated. The most vocal anti-vax guy was the first one in line for the vaccine, and that kind of led to other people, but it took a lot of discussions, not just a one-hit wonder to get them to that point. So my learning is that you have to have 3 to 5 ways of providing information to these people who are in that space. I'm on the 14th time with my own brother, who's a caregiver for my mother, and he still won't get this vaccine. So now there's a lottery with a whole lot of family members to get him this vaccine. Whoever gets it, it gets a pot. So at this point, I'm in a desperation stages with people like that nothing that you say or give them seems to move them. And they may be those people that are not in movable middle. So we're going to stick to the movable middle and try to get those folks and leave people like my brother in their space. So that's what I would say. Do what you can with who you can.
Dr. Biel, I just want to jump in and just say, if you have resources, anything associated with that series of talks that you had, please share and we will happily disseminate.
Okay, thank you. I'll put it in the chat if I can. Otherwise, I'll email you after.
Dr. Biel, I asked if I could.
What was the question?
It's me, Sheila. I said I'd like to join so I can join that lottery.
Okay. Yeah, it's gotten up to $1,500, and it's with little church ladies and people putting in $5. So we're going to see. We got an end date of October 15th, so we'll see.
I really very much appreciate everyone sharing your personal anecdotes and all of the very creative ideas that have been introduced to the space. It's really extraordinary. we want to shift the conversation just a bit unless there are others who want to share on the topic we were just discussing. I'm wondering what, if any, are you hearing about variants from the communities where you are serving? Is there concern that's being raised or anything, misinformation? So we want to talk a little bit more about that if people would be willing to share.
I'll go first. I think that there's a lot of concern overall about going back into sort of our everyday environments and what our environment's doing to help keep everyone safe. So that's one thing that I've heard about regarding the variant. Also, folks are concerned about their kids going back to school. The prior variants or strains, didn't affect kids as much. This is affecting kids more. So, parents are really concerned about that. I bought some, I think I have it here with me, a KN94 mask for my daughter. She's in 10th grade and gave some to her class as well. They just bought filters that are going to be in the classroom. So, there are other things that we can do. Again, this works. We know that when we put this on, we'll go into or not this one specifically, KN95, we'll go into the room of a patient who has TB. If we don't have that, we won't go in. So, we have to utilize again what we have and really encourage folks to wear a mask indoors. And again, I think that folks are concerned about those who are unwilling to wear a mask as well. They're concerned about those who aren't vaccinated, especially with the variant. But I think that there's still a group who doesn't necessarily care at all that we're in a pandemic. And then there's a group that's very, very concerned.
I just want to add to that I definitely see two far extremes. A lot of the reopening schools, town halls, I think parents care a lot about their children and they are very frightened about sending their kids to school or for doing the right thing or for putting medicines into them that can have long-term effects. So I hear or can at least try to empathize where the extremism in parents are coming from. But at these town halls, we see one end, which is you're sending our kids to school to die. And on the exact opposite end, you're poisoning our children with these vaccines. And it also is fascinating that the extremes both come from both extremes of both parties. And so it's this weird discourse that's in the back, context or, you've got healthcare, public health, policy, all kind of intersecting. And I think it's all getting wrapped up. And unfortunately, it's fanning some of those flames in these political forums. I mean, masks amongst children should not be this controversial. It should be another layer of protection. Same thing with the vaccines. We vaccinate our children for so many childhood vaccines, and yet this one seems to really disturb people that this is affecting their fertility and all sorts of things that we've just never seen with vaccines in general. So there's some very unique things happening in this context. I will say though, where are we going from here is what I'm keeping me up a little bit. Are we going into a cough and cold flu season? Will rates increase? We can't predict that. Will uptake and use of vaccines and all the public health recommendations increase? Will we see over time more mild strains and this does turn into a communicable disease that's preventable, treatable, that our strategies work and we kind of keep going along in this new normal in 22 and 23. And that's really hard to predict and plan for because depending on which route we go, if we're looking at a serious fifth wave, if there is a more deadly strain, a more contagious variant, it's going to require a different 2022 strategy. But if we're seeing something that we're going to learn to live with, then we're going to have to embrace learning to live with these strategies in a way that doesn't divide or destroy our communities and realize we're going to have to also build on some of this that's happened this far. So I think those are things that we should all be kind of at least aware of and looking to as we head into the fall, the winter, and where vaccines, COVID land in the next few years?
Thank you for everyone who has shared so far. I'm wondering now, we've talked a lot about things that did and didn't work. I guess, just moving forward, even though we are definitely still within the pandemic, what things went well, what things didn't go well? What are people's perspectives on that?
This is Tracy Biel, and I'll start with some things I saw that went well and some things that did not. Public health made a decision to try to get the more shots in arms at these big, large sites. So if you didn't have a car, if you didn't have certain technological access, you were kind of left behind initially. So to me, the best approach would have been understand the volume need, and there was limited vaccine initially, that it would have been great to have a parallel track at that moment in time to help people in the hard hit communities specifically go into those communities simultaneously instead of one versus the other. So that took a few months, and those few months there were lives. So in my opinion, if I could do a do-over for the nation, I would say nice to have the big sites, but those very hard hit communities, even if you could do the top 3 to 5, needed it then. So that's one learning I have. And also you have to have people at the table who have the lived experience that they didn't have a car, they didn't have technology. So someone is voicing these things that need to be taken into consideration and not kind of pushed aside so that the people who have advantages get to the front of the line. So those are the two things that really stand out to me, and I'll defer to some of my other colleagues. Thank you.
I would like to add to that, if it's okay. I definitely think this is going to be someone's academic life work easily, looking at COVID-19, looking at equitable vaccine distribution in America, the whole vaccine debate. But I would add to a lot of what Dr. Biel said. The phases and tiers were complicated. Not having geo-based strategies really killed and hurt a lot of people. We prioritize people on theoretically risk. Oh, you work in healthcare, but how many of those individuals were actually telemedicine or not actually interacting with the public? Many people found creative ways to cut the line, the digital demons, and we created a digital fortress that divided people and left them all out. So that's why it was so critical for Kedron to demand the vaccines first and foremost. I picked them up. I literally went to the warehouse, knocked on the door, said, I'm not leaving. I brought cameras with me, and that's how we got started. And I said, you're not going to give me enough for my nurses and my patients. We're going to only do this if you give it enough for our community, as we were in very hard hit South Central and South LA. And so with that agreement, that's how we became a point of distribution for the county. And that started that whole race of breaking down every barrier. How many toes did we step on? How many times did I have to apologize? Oh, I'm sorry. We're going to see people whether they have an address or not, whether they have an appointment or not. We bucked that system and we piloted the zip code based strategy and the household based strategy. If you've got one person positive in that house, doesn't that tell you already that household's probably one of the main houses that needed these vaccines? Number two, if you live in a zip code where people are living and dying with COVID, why wouldn't you think about prioritizing that as a measure or an indicator for getting you in for a vaccine? And so a lot of this pushback and dialogue had to happen, but clearly we were not all at the table. It's a critical issue. We need to, make sure that that continues to be prioritized, because there was a lot of this, oh, we never thought about it. And our immediate response not only was how, I don't understand how you could not have thought about it, but also, who were you asking? Who was in the room with you? Why did you take this approach to begin with? And you really do have to turn some of these decision-making paradigms upside down. And I'll also lastly agree with Dr. Biel. The mobile efforts, we didn't really see those launch till March or April. Those really should have been starting back in December. And we should have been able to repurpose some health infrastructure appropriately to go out in that fashion. It probably needed all of it, because without the mass sites, you wouldn't have gotten so many large, high volume of our seniors vaccinated. But we wasted a lot of time by waiting to start mobile months into this game.
Thank you so much for sharing all of that, Dr. Abraham. I agree 100%. And of course, Dr. Biel as well. One of the things that I'm going to say right now is that, you know, we have to understand what we're dealing with, and we have to understand that racism still exists in medicine. We were able to show that the price of housing mirrored the cases for COVID-19. So essentially, if you look at the median home index, you could overlay that on the areas of Los Angeles County with the highest rates of cases and deaths. And so it's not an accident. Yes, we keep getting in trouble. We step on toes because we care, right? We're out there pushing, but we have to understand that fundamentally that we're also living in a world where people are selfish, period, where people are thinking of themselves and not the greater good. That's why we had folks who were from, you know, Malibu or other places. I'm not saying anything about people from Malibu, but they were coming to South LA to get vaccinated. And, you know, again, yes, people had the information. It's not that people didn't think about it. It's that they didn't want to, because we had already shown, we had already demonstrated how to be effective, especially in South LA, in our area. We told them our strategies. We had to, you know, implement those strategies, sort of letting folks know after the fact. And so it's not that people don't know, it's that we have to, as the physician community, have more influence on how our healthcare dollars are spent, how decisions are being made regarding who has access to healthcare and who doesn't, who has access to vaccines and testing and who doesn't. Sometimes, Dr. Abraham, we're purposely left out of the table, you know, purposely left out because folks know that we're going to advocate for the community. And sometimes there are folks who really don't want that. They want to use resources in other places. And so we have to be aware of that. And then we've just got to work with what we have as far as using the resources that we can garner to support the efforts that we're trying to put forth. And one of the main things that we do have to do, and that this pandemic has shown us, is that we need more people, whether they're people of color or people who are passionate about working with communities of color, not just to come to South LA, get their experience so that they can show that they did their community service working with underserved. They can write it in their personal statements and then go off to med school somewhere and never come back, or never really have a heart to come back. But we need folks who really want to serve in these communities, and realizing that this community, you know, it's in multiple countries around the world. So many countries are, you know, underserved. We haven't even gotten to the, Dr. Wallace brought this up earlier, but the fact that some countries don't even have access to vaccines, period, right now. And, you know, we're being looked at as these monsters for taking, you know, boosters for people who don't need them. So I think overall, we've got to look at the fact that racism in medicine exists. We have got to train and accept folks into medicine who care about all people, regardless of their social status, their economic background, their religious or cultural or ethnic background. And, you know, that's the true spirit of what a physician is. And, you know, it's a right. I mean, it's a privilege to be able to care for people, to have someone's life in your hands. And so, you know, why should we differentiate, you know, who's more important and who's not? You know, as a person who's undocumented, are they not as important as a CEO of, you know, a big corporation? In our society today, the answer is they're not as important, but that's not a healthy place to be as a society. And so those are the things that we've got to work on. We've got to educate more people. We need more clinical sites. We need more hospitals. We showed prior to, Los Angeles having a surge in cases back in the spring, that there were only about 52 ICU beds prior to the pandemic for 1.6 million people. And that's not acceptable. So there are multiple layers that we need to work through. COVID-19, yes, has exacerbated or brought more attention to, has truly hurt the community in so many ways. But we've got to look at the systemic issues, and we've got to address those. And we've got to root out all of those systemic issues that are causing our community members to die.
I agree with all of my colleagues. The points that Dr. Young just made are points, some of the points I was going to make. This is, to me, a new face of an old enemy. And we will, at some point, move past COVID-19, but there will be something else. And then there will be something else after that. And I think what this has lit a fire and a torch into many people, myself included, is the reality that social and structural determinants have to be a priority and a focus for all of our efforts going forward. And that health equity can no longer be a catchphrase, that we really need to dig our heels into this and deeply, and address this at all levels in our institutions and in our government. It is, in my mind, really important that we also take note and take stock of the reality that this effort, even more so than the most recent sort of reckoning regarding race relations in this country, is going to piss people off. Is going to move people to a place that they are uncomfortable, and there will be a reverberation as a result. So we need to be aware of that as well. We can't naively walk and march and think that people are not going to have a response to our advocacy in this way. But I do think that, we need to be meeting as Black communities to structure our plan of action, both in local settings, at statewide settings, and at a national level. We need to be meeting, we need to be thinking about this, we need to be pulling on our allies, those non-Black people who suggest that they're allies and want to work with us and partner with us in this effort. But we collectively have to get a handle on this. Because this is not going to be the end all be all for sure.
Thank you for everyone who shared on that, and really well said all of the comments that have been made. I did want to address a question. I think it was an anonymous question earlier about, someone who had gotten the Pfizer shot, was age 55. They completed the COVID-19 Pfizer vaccine series, and they wanted to know, do they need a booster and why? And so I saw Dr. Abraham address that question. Thank you. And I'll just add to that by saying the reason why is because we are seeing reduced protection against mild and moderate disease, in particular with regard to the Delta variant. And this is why the need for a booster has been recommended. The timing of this, certainly I encourage that individual. I hope you have a doctor who cares about you. And if you need a referral, we're happy to provide you with one, someone who can review your case and give you specific information. But that's a general answer to your question. And I wanted to ask the panelists to comment on how some of the things that have worked, some of the strategies that we've seen work in responding to the pandemic, how this could be applied.
You muted, we can't hear you.
Oh, I was talking for a long time. I'm so sorry. Yes, I apologize.
Lessons learned from the pandemic.
Sorry, say that again, sir.
Lessons learned from the pandemic.
Right. I apologize. I was trying to address a question that someone put in the chat earlier, an anonymous individual who said they're 55, they completed the COVID-19 Pfizer vaccine series. They wondered, why do they need a booster? And I saw Dr. Abraham address that question. Thank you. I wanted to, oh, you did hear that, great. So now my next question is, what can we apply in terms of what we have positively learned from the COVID-19 pandemic toward other health challenges such as HIV and substance abuse? Anyone with a response to that?
Happy to jump in. I think that the lessons learned are many. Some of what I highlighted on the 30,000 foot level in my last comments. But I guess more specifically, one of the things that we're doing in the HIV Vaccine Trials Network is looking to utilize mRNA vaccine development to respond to HIV vaccines. So we're looking to start that program really soon. Really excited about that. There are other things that I think are really important, and Dr. Young and my other colleagues have spoke to this as well. And as we also need to address health literacy in our communities and research literacy in our communities. It's not enough to continue to give people the fish when they're hungry, but we really need to do better to teach people how to fish, how to navigate misinformation, how to filter out misinformation, and more specifically, where to go for accurate information, and building trusting relationships with communities to do that work. And that is something that I think all of us play a part in.
Definitely feel that, at least from our mobile experience, I'm realizing we need this type of rapid response public health infrastructure moving forward longitudinally, regardless of whether you're in a pandemic or disaster or emergency or not. Just like you can call 911 and get an ambulance to your home to take someone maybe in cardiac distress to a hospital, there has to be a way to mobilize public health interventions into the live, work, worship, play, school, homebound model. And you need to be able to pivot it, as you know, Dr. Young and Dr. Biel mentioned as well, and titrate it up and down based on the need. So really this needs to look like some sort of community response network. We have the National Service Corps that staffs, you know, primary care clinics or the federally qualified health centers. You've kind of got the Red Cross thing. AmeriCorps volunteers were involved through all this. There are other volunteer corps, but really to have a public health devoted corps that is doing peacetime missions. So it could be working on all sorts of issues, but really be able to mobilize them for the massive public health interventions needed, I think is something that we should explore, because this really is an emergency response team for public health crises, which the public health department cannot be the only entity in this. It's not going to work. There's just not enough resources. It needs to be in these public-private partnership formats that include all types of organizations, but they should be able to lean on, just like a hospital or just like the county healthcare delivery system can lean on ambulances and other resources. Similarly, there should be lifelines of public health throughout the community that can truly be activated and respond. And they should be from our community, not always people who come from external places. There should be people within our communities, within our housing, churches, schools that can be activated, turned on for this, quick, rapid response that took way too long for all of us to really organize.
Those are really great. Thank you for both of those responses. I want to amplify a question from Dr. Chapter, which is in the chat, and invite anyone to answer. What efforts are being taken in Los Angeles County to push health equity for Black or African Americans?
This is Tracy. I actually got to know quite a few of the providers on the call because I launched the Equity Committee for Public Health. And part of that was to make sure we took in the external perspectives on what needed to be done. So that was an ongoing organization that has had a lot of impact not just in California, but also with federal legislation and other mandates. So for example, California was the only state that set aside 40% of vaccines for these equity areas. And part of that was the push from a lot of leaders like Dr. Abraham and others in the community pressing for that. And so the heavy lift that had to be done was done through a lot of stakeholders and partners outside of public health that look like the people we're serving versus a different approach. The other thing that goes on that people don't see is every week we predict outbreaks and we actually monitor the outbreaks and we realign resources, and most of it is in vulnerable communities and communities of color. We realign resources, everything from community health workers that mirror those communities to vaccination sites to education, and even in the schools, we try to pivot the resources to the extent that we can for those communities and make sure that we map every available vaccine location in those areas to make sure access is equitable in those communities. So it may not be the pharmacy, it may be the church or other local produce market or a retail store, swap meet. So we try to meet the need by finding other locations to meet those needs in those communities to make sure they have the access they need. And we've expanded the hours. One site we had 65% Hispanic males come, and we realized it was because the vaccine time and the weekend date that we did it, what we continue to do it, allows people who work different hours. And I know others on the call have been very good about doing that. So those are some of the measures we do. We actually track to the detail whose shots in the arms do the vaccines go in by ethnic rate, ethnicity, by age, by location, by zip code. So we do a lot of analysis to try to make sure that if people are not getting the vaccine, it's not because of access anymore, and it's not because of other barriers that were initially part of the challenge. Thanks.
I just want to jump in as well, and just say that we, as much as we've been discussing health equity, as much as we've been discussing, this desire, the proof is going to be when we actually do it. So we went from a 500-bed hospital at MLK when it was King Drew to a 120-bed hospital. We went from a level 1 trauma center to level 2 or not necessarily having trauma services. So we understand, we know what the disparities are. We just need to allocate the resources, the human resources, the capital resources, so that we can right the wrongs that have been done in this community. We have an opportunity to build. We have an opportunity to create. We have an opportunity to serve. But we have to get our legislators, we've got to get everybody on board to support this. Right now at the university, we need more places to train our students. We can't train across the street. We're working on it, but we need more locations. We're building a medical school. We have a PA program, nursing programs. We have kids from kindergarten through fellowship that we can put into the community in a very short period of time. And so, we have an opportunity now to take a step back and look at what's happened in South Los Angeles and East LA and reallocate our resources. We must do it. We cannot sit back and let this happen again. If we do, then the lives that are lost in the future, those are on our conscience. And it should be on our conscience because we have an opportunity. We know what to do. We can do it. We just have to be willing. So then how do we get folks to be willing to invest? People pay their taxes here. Even though, and people actually, benefit so much from the workers that live in this community. Every person who lives here deserves healthcare and deserves providers who care about them, regardless of the fact of, whether they have documentation or not. Who's making your food at 5-star restaurants? Who's cleaning your home? We have to start really caring about everyone, and we've got to invest the resources.
A call to action. I'm sorry, were you still speaking? I didn't mean to interrupt.
No, I just saw something in the chat, and so I didn't see what it said necessarily.
What you had to say was really a call to action for all of us. So I think it's a great note for us to conclude on. And I just want to thank everyone for attending, all of the speakers, our panelists, for your time, sharing your insight and wisdom, the work you have been doing in this space for so long. Really appreciative of that. Thank you to all of the community partners and members. The video for this will be posted on the CHIPS website, and the evaluation will be emailed out to those who registered. I believe that, there's a survey that's been posted in the chat for people to complete. There was a PSA video that one of our organizers is going to share at this time. I will happily turn things over to Dr. Usup after that video plays. Thank you very much.
I got vaccinated for my family.
For youth sports.
To go back to school.
For my homies.
Let's get the whole country vaccinated. Let's end this global pandemic now.
This is based on math and science. This is a great way to prevent people from dying.
Los Angeles, get vaccinated.
I didn't realize we had some celebrities on this call, some vaccine celebrities. I'm looking at you, Dr. Abraham. We want to again thank you all for attending, and I think we had a very exciting raffle. Dami, are we ready with those raffle results? So please direct message Dami your email address so she can be in touch with you to get that raffle. Again, I want to give a huge thank you to Dr. Adeyika and Dr. Clark for moderating such a fantastic discussion. We will follow up with everyone with resources from this conversation, and we look forward to ending this pandemic together. So thank you for joining us this afternoon, and thank you for all of our speakers, and most importantly, thank you for attending this community.